I'm Dr. Chacko Periyapuram. I'm a heart surgeon working with one of the Christian mission hospitals in Cochin, Kerala, called Lisi Hospital since the last 15 years. I'm mainly involved with heart disease. I'm also involved with heart transplantation, valve replacement surgeries, bypass surgeries, as well as structural heart diseases. I have up till now performed nearly 20,000 heart surgeries, about 30 heart transplantation, and I have also performed the first redo heart transplantation in India, as well as the first heart and lung transplantation in the state of Kerala. A layperson hear about minimally invasive cardiac surgery, that they mean that they need to have a small incision, a small cut. That is what a layman's point of view of minimally invasive cardiothoracic surgery. But from a surgeon's point of view, the major invasion is a physiological invasion, whereby using a heart-lung machine or avoiding a heart-lung machine makes the surgery minimally invasive, because the biggest invasion to the human physiology is connecting the human circulatory system to an outside machine through which the blood flows for many hours. So in essence, there are two minimally invasive procedures. One is avoiding heart-lung machine itself makes it a minimally invasive procedure, and also making a small cuts or no cuts on the body to do surgery also is a minimally invasive procedure. Beyond the size of the incision, having a small incision for a major surgery will reduce the in-hospital stay. It will reduce the pain related to a procedure, and the recovery after the surgery will be faster, and getting back to normal life, getting back to the job which the patient was doing will be much faster. So that way, minimally invasive surgery has got a big advantage over the conventional, more invasive procedures at the moment. In the past, when I was trained as a doctor abroad, the most commonly used valve was a mechanical valve, and the tissue valves were very rarely being used. But the fact that a mechanical valve, after the implantation, the patient would need to be on anticoagulation medications or blood thinning medications. So basically, we are converting a valvular heart disease to another disease called the need for anticoagulation or blood thinning medications. Blood thinning medication, obviously we know that can produce a higher incidence of bleeding. The bleeding can be minor bleed or can be major bleed. It is calculated that about 3 to 4% of people who are on anticoagulations after valve replacement surgery will have minor bleeding incidents, like bleeding from the gum, or bleeding from the shaving side, or bleeding from a small cut in the kitchen. That's a small bleeds, to a bigger incidence of bleeding of about 0.9% per patient year, which can involve a major gastric gut bleed or even intracerebral hemorrhage, which can lead to loss of life. So it's very important that we should try to avoid anticoagulation by any means possible, and that way the tissue valve is actually becoming more and more popular in the society at the moment. When I was being trained, we never used to put tissue valve above the age of 60-year-old patients. But now we do it on young people, because the younger group, most of them are very dynamic, they are active, and they are very sporty. And probably they will go to rare places where the medical or health care may not be available, like skiing in the mountains, or doing some kind of a aggressive sporting, whereby they become prone for injuries, and during which time, if they are on blood thinning tablets, they can have a life-threatening or devastating bleeding, which probably may not be able to be attended by a doctor in the right time. So definitely the age at which a tissue valve is being implanted is becoming less and less, and more young people are opting for valve replacement surgery using tissue valves. And like surgeons like us, definitely will encourage them also. A special thing which we should think about is the valve replacement surgery young women who belong to a childbearing age. When a lady becomes pregnant, we don't want the lady to be on blood thinning tablets because it can produce complications on the embryo as well as the intrauterine life. So it's very important that if a woman is going to have a childbearing age or want to have a child, it is even if the tissue valve lasts for only 10 years, they can probably very well manage a pregnancy by using a tissue valve and tide over that childbearing age, after which they can go for a longer term valve replacement using the blood thinning tablet. So it's important that there are certain subgroup of patients who definitely has got a stronger indication or strong indication of needing the tissue valve, as well as for their life, for their family life, as well as for their personal maintaining their personal quality of life. See, anticoagulation is a major issue, as you mentioned in your question itself. As I said earlier also, the anticoagulation can have a lot of side effects, and when we offer a patient a blood thinning, a mechanical valve which need a blood thinning medicines, we actually assess the patient as a person, whether this individual is a very disciplined person. Some of the people will just do have the replacement of the valve done and they go home and they probably take it easy and they may drop the doses, they may probably don't take medicines, they may not probably check the blood INR. INR is an international normalized ratio which is 1 in a normal individual, and that shows the thickness or thinness of the blood. And by giving certain medicines, the blood thickness has to be reduced to at least half of what it is normal levels, and the effect of the medicine is being checked by INR. If the INR goes too high, that means the patient is taking more dose than what he needs, and if the INR goes too low, that means the patient is not taking enough medicine. Once we give or implant a mechanical valve to a patient, we have to emphasize the patient about the absolute discipline they have to follow in their life for the rest of their life, by taking the medicines at a regular time, at regular intervals, monitoring the INR and keeping at the suggested range. Very important. Not keen on having a second procedure, for which reason they will probably ask the surgeon to put a mechanical valve. So I think it's always safer to have a tissue valve, especially for our population. And with the manufacturers coming out with the new generation valves which last longer, and with available procedures of re-operation or implantation of valve, I think it is a responsibility of the doctors to educate, or healthcare workers to educate the patients to favor implantation of tissue valves, though mechanical valve is in the market and it can be used in certain special indications.